Okay. All right. Awesome. Okay. Hey everyone, thanks for joining us today. My name is Ami Tour, and I'm the president of the Biomedical Ethics Club here at UCR. Welcome to our third guest speaker event. Here at BME, we place a heavy emphasis on local, domestic, and global health. And we want to make it clear that we stand with communities of color across the United States and that we have the well-being of the fallen in our thoughts and prayers. So today we have the honor of having our guest speaker, Dr. LeComte Hinely, the CEO of the Health Assessments and Research for Communities Incorporated, also known as the HRC, who received a doctorate in applied psychology from the Portland State University. Dr. LeComte Hinely has been at the forefront of developing research in the fields of wellness, public health, and gender disparities in the workplace, especially in the Coachella Valley region here in the Inland Empire. Hi, Dr. LeComte Hinely. Thanks for being here today.
Thanks for having me. I'm honored.
Absolutely. So if you would like to do a quick little presentation, the social determinants of healthcare, that would be greatly appreciated. And
Sure.
it's really good to have you here today.
So, just a little bit of housekeeping. Since we're all far apart due to COVID, but I do still really value an interactive sort of format. So please feel free to use the chat box and be sure that you click to all panelists and attendees. I was giving a guest lecture to medical residents a couple of days ago, and I realized I kept saying things like, "Oh, that's a great question," but they'd sent it just to me, and so everyone else in the audience was like, "I don't know what she's talking about. What a great question is." So if you do participate in the chat, please do make sure that everyone can see it. And I also want to do a couple of polls. So right now I'm launching a poll, and I would like to know what your major is. Obviously, in terms of biomedical ethics, that can come from a wide variety of fields and majors, but I want to know a little bit more about each of you. So it looks like 4 of 6 have voted, so I'll give you a couple more moments. All right. So looks like you guys are representing biology, so thank you so much. And now I want to hear a little bit more about you and your career. So tell me, I mean, if you had all the resources in the world, what would you be doing with your career? Okay, looks like healthcare provider, but physicians are the way to go. And it's great that you're at UCR because, as you know, the medical school there is awesome and reserves spots for people who went to undergrad there. So I'm also on the community advisory board for School of Medicine and several grants with them. So obviously I'm a big fan. I think you all should go there. Okay, so let's jump in. As was mentioned, I have a PhD in psychology, which is quite a bit different than bio, but my area of expertise is occupational health psychology, so very much around how to keep workers happy, healthy, and productive. I have been a CEO of HARC for a little over 5 years now. I started as the director of research and then became the CEO when our CEO retired. I've also taught statistics for the health sciences, and I've been a researcher and evaluator in a variety of other settings as well. So the research that I do is probably quite a bit different than the research that you all do in the hard sciences. My mother is a physicist, and so she has always emphasized the difference between the soft sciences and the hard sciences. So for you, it might be a lot more of labs and cells, and for me, it's more of people's opinions and that sort of thing. But research is research, and research is awesome. So HARC is a nonprofit that's based in Palm Desert, so just about an hour away from you all, assuming that you're actually in Riverside, which may or may not be the case these days. And our whole goal is to improve community health and well-being and quality of life through data. So we have 2 major services, and I'm going to briefly talk about each of them. One is our Coachella Valley Community Health Survey, and the other is customized services that we do. So we are basically a bunch of data geeks. And when I say a bunch, I actually mean 5. There's 5 of us. We are small but mighty. And actually, when I started at HARC, there was only 3 people. So really, we've had almost 100% growth in the past 8 years. So we have a really tight team. We're very close. And actually my newest team member isn't in any of these photos because she started 2 weeks before the pandemic lockdown. So we don't have very many pictures of Amarani, but this is our team prior to the pandemic. So HARC was formed because people in the Coachella Valley felt that they didn't have good data to represent their needs. And while there's great data available at the county level, Riverside is a huge county, right? It's bigger than some US states on the East Coast. And so the county level data was actually kind of suppressing the issues that were happening here. This is the same way that you really need to collect demographic data, because otherwise you end up suppressing things like racial disparities and health inequities. So our story wasn't being told. I say our, I wasn't here then, but I have fully adopted Coachella Valley since. So they said, okay, how are we gonna do this? Let's do a random digit dial telephone survey, and the random sample is important, so it's actually representative. We'll call cell phones and landlines. These days it's more cell phones than landlines because not that many people have landlines anymore. It's conducted in English and Spanish. Those are our two primary languages in the Coachella Valley. If we did it in Riverside, we'd have to include a lot more languages. We talk to adults and adult proxies for their kids because nobody wants to get into the ethics of talking to children on the phone. That's just a whole can of worms that I don't want to open. And we provide the data back to the community for free. So this is our latest and greatest report, and you can download it for free on our website in case you want. But it is about 130 pages, and that is literally just the tip of the iceberg. We call it our executive report, executive summary. It is literally just the tip of the iceberg to sum it up in 120 pages. Most of the people who use our data are other healthcare organizations or nonprofits that work in health and human services. For instance, our local hospitals here use it to recruit physicians, right? To say, hey, this is your patient profile. This is who we need you to come treat. Please consider practicing here. And nonprofits often use it in their grant proposals. So they use it to say, this is a major issue. It affects this many thousands of people. Please give me money to help address it. Now, the content isn't driven by a model or theory or anything. It's driven by the community, and the community members saying, you know what, I really need to find this data and I can't find it anywhere else. And that last piece is really important for us because obviously if somebody else captures that data, awesome, great, no need for us to do it. For instance, somebody said, oh, well, I want to know more about CalFresh. The county has great data on how many people are getting food stamps. We don't need to collect that data. So because it's community driven, it covers a whole variety of topics from healthcare access and insurance and utilization, usual source of care, also things like major disease and mental health, disability. We have a really broad section on demographics that covers not just, race, ethnicity, age, gender, but also sexual orientation, gender identity. We cover whether or not they're a veteran, and if so, were they deployed, whole 9 yards. We also cover things like obesity and exercise and nutrition and food insecurity, some things about drug use, some drinking behaviors. We've covered sleep in the past, so really, really broad. This is what happens when you ask the community what they need to know, and the needs are very great, and nobody ever wants to take things off. They always want to add more. So the survey keeps growing and growing. Our most recent one, the 2019 survey, took about 30 minutes to complete on the phone. So that's a wee bit long. I know I don't like to be on the phone for 30 minutes, so we're gonna have to adapt next time. But anyways, that has been our service to the community, right? Is to provide this for free. And many of our donors and funders give us money specifically so we can continue to make this available for free. So it's a 3-year cycle. We do it every 3 years. And it really is work all 3 years. It's basically like 1 year to plan and get ready, 1 year to actually collect the data, and then 1 year to disseminate it out and make sure that everybody who could benefit from it knows that it's there. But some years are definitely lighter than others. And so in 2009, the idea was, well, we can do things other than just this survey. we can do research and evaluation for others. So we basically do, again, we're data geeks, so we do anything related to data for others who would like to be evidence-based, but who don't have the funds to have somebody on staff full-time as a researcher. So for instance, right now, we're doing a community health needs assessment and community health improvement plan for Desert Healthcare District. We've done client satisfaction surveys for federally qualified health centers. We've done evaluation of fall prevention programs for seniors and literacy programs for kids. It's so broad and so diverse and so fun. I think I would get bored if I was always doing, let's say, fall prevention programs or always working in the senior sphere. But I'm not. You go from one day to working with seniors to another day working with kids to another day working on LGBT issues and HIV testing, and to another day talking about housing and how we can house people and prevent homelessness. So it's really fun. You get to keep learning all the time, and all of the work that we do really pertains to quality of life, which I really enjoy. As a researcher, you can do research on other things like market research, but I don't think I feel good about myself at the end of the day if I was saying, what's your favorite color of M&M? Or what should our new color of M&M be? Like that, who cares? That has no impact. Maybe it has an impact on profit sharing, but it doesn't have an impact on people's lives. All of my clients are trying to make life better for people. And that's true whether they're a for-profit or a nonprofit, they're all doing work to improve lives. So that's what makes our team really happy, is that we're a part of that. So that is my background. But Jonathan mentioned wanting the topic of this to be on social determinants of health. And I'm really excited about that because in the work that we've been doing recently, we've found that more and more health systems and healthcare providers are shifting their focus to talk about the social determinants of health. And it's really necessary. So I want to start off by hearing how you would define health. And so write this in the chat box. When somebody said, some alien comes down from another planet and says, what is this thing called health? What would you say? How would you describe it? I'm not saying anything in the chat box. Come on, guys. While you're thinking about it, I went to a website, DuckDuckGo. Unlike Google, it doesn't track what you've been researching or looking up. And so this is purely the top things that popped up, the top images that popped up when I did an image search, when it had no information other than I typed in the word health, right? So this first graphic, I'm not sure why there's money involved, but there's a heartbeat. You've got a little DNA strand, you've got some pills, a stethoscope. This light bulb one has some mental health, as you mentioned here. Again, you got some more stuff. You got a lot of stethoscopes and a lot of little EKG type of monitors. I'm loving the comments that you're saying. Status of your well-being, best attainable standard quality of life. That's a really good one. So when you hear health, most people think about physical health, they think about healthcare. And I know this because when I first came to HARC stood for Health Assessment Resource Center. And we changed the name because people would call and be like, hey, can I get cheaper Medicare? And I was like, I don't know. That's not what we do at all. So we changed it to Health Assessment and Research for Communities, which much better describes what we do. But I really wanted to stay away from that word health because this is what people think. They think doctors in white coats, they think stethoscopes, and what we do is so much broader than that. And I literally got an old-fashioned dictionary and went through the H section. There are not a lot of great H words. So we stuck with health. But this is what people think about when they think of health. It's very physical health, healthcare. So the dictionary has a couple different definitions here. I like this first one, the condition of being sound in mind, body, or spirit, and especially being free from physical disease or pain. Two of these are really vague in general, but I really like 2A, a condition in which someone or something is thriving. So that positive aspect, right? It's not just about disease, it's about how are you doing well. The World Health Organization has what I consider to be the best definition. It's a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So if you think of that as your definition of health, it becomes clear that you're not just talking about symptoms, you're not just talking about disease states, you're not just talking about what happens in the hospital. Social well-being and thriving includes all of these other aspects, and that's where social determinants of health come in. So this is a very blurry picture, I apologize. This is the model from Healthy People 2020. And Healthy People 2020 has identified 5 key social determinants of health. Economic stability, which to me, I think is the biggest one. To me, you cannot be healthy if you can't afford enough food. If you can't afford a roof over your head, and you can't afford food, and you can't afford clean drinking water, everything else goes out the window. And once you have all that, you can get things like a good education or a strong neighborhood with safe spaces. You can go get that healthcare. You can have a supportive community. But to me, everything comes back to economic stability. But all of these are in their model. Now, the Kaiser Family Foundation, which is another really awesome source, they added one more to the model that Healthy People 2020 has. They added food, because like I said, when it comes down to hunger, you cannot be healthy if you're not getting enough nutrition. They also have access to healthy options. That goes into the concept of food deserts and whether there's any healthy things that you can buy within walking distance of your home. And so Kaiser Family Foundation pulled out these particular aspects, right? Housing, transportation, safety, parks, playgrounds, and they found that these all have been linked to healthcare outcomes. Well, health outcomes and healthcare. So that comes down to, that predicts your mortality, morbidity, your life expectancy, but it also predicts things that matter in a medical setting, like healthcare expenditures, your health status. It can even predict disability. So this is the county health rankings model. And I was first introduced to this when I came to the desert and the Clinton Health Matters initiative was functioning in the Coachella Valley. And this really shocked me, right? And because all of you want to become doctors. And so you're thinking, this has a huge impact. What I do has a huge impact on people's health. And it absolutely does. And what you do is so important. And we are so happy that we are growing our own doctors here in the Valley, here in the Inland Empire, because it's so needed. We have the worst primary care physician rates to population in the entire state of California. So we so need you. But that's only predictive of about 20% of your health outcomes. The rest comes down to things like the social determinants of health. It comes down to your income. It comes down to your air and water quality. It comes down to the behaviors. What is that person doing? You can provide them with great, great health care. But if they are, drinking a fifth of vodka a day and smoking 3 packs of cigarettes, your health outcomes are gonna be terrible regardless. So I thought it was really interesting that when we talk about health, people have that stereotype, doctors and stethoscopes and white lab coats, but that really only accounts for about 20% of your overall health factors. Now, I want to do another poll. So tell me, all right, where you think Riverside ranks in terms of health outcomes, right? These are our length of life and quality of life. I forgot to end parentheses. That annoys me. But anyways, there are 56 counties in California. Number 1 is the absolute best. And 56 is obviously not doing so hot. All right, we've got some votes in. It looks like you guys are very pessimistic about it. All right, let's share the results. So one of you said somewhere in the 21 to 30 range. And then most of you said either 41 or worse. So not doing so hot. So let's real quick. Let's go to their website. Yep, that's not what I meant to do. What I meant was, okay, so this is the health outcomes and the factors. You can see here, here's us. In terms of health outcomes, that's overall length of life and quality of life, we actually rank pretty decently, 26 out of 56, so right there around the median. In terms of health factors, all those behaviors and such, shouldn't have clicked on that, sorry. We are not doing nearly as well, right? We're down there in the 30s, but not terrible. There are definitely some worse. And if you do want to, I highly recommend you explore this. So if you do click on it, it shows you here in order where people rank. San Bernardino is 41, so slightly worse than Riverside. And all the way down here, you notice that actually a lot of the counties that are really, really at the worst are the really small counties in Northern California. And let's see who's doing the best in terms of health. Marin County. I have relatives in Marin. It's extremely wealthy, so not surprising. They are doing pretty good at things like their behaviors and their access to care. So, so that's the county health rankings model. We did a community health needs assessment for Kaiser. Every nonprofit hospital is mandated by the Affordable Care Act, and before that it was by the IRS, that because they are nonprofit, they're not paying taxes, you have to give back to the community, right? And the way that they give back is they need to assess what are the needs in their community, and then they need to create this plan. Okay, how are they going to address those over the next 3 years? So we were fortunate enough to get the contract to do 2 Kaiser hospitals, Kaiser Riverside and Kaiser Moreno Valley. So that covered most of Riverside County and a little bit of San Bernardino County, the high desert up by Joshua Tree. And this is one of the things that I found really, really interesting, right? This is what social determinants of health are linked to health outcomes. And you can see here that, and this is statistical linkage, right? There's a statistical significant difference. If you have lower income, you are more likely to have more poor mental health days. You go to the ER with a heart attack. You are more likely to have asthma. You're more likely to be obese. It goes on and on. So this is a very real, very tangible outcomes. It's not just a theoretical, these things matter. It is very, very real. You can see that, as I mentioned, income has a huge impact, right? It impacts what? 8 of the health outcomes. 8 outcomes are impacted by you being low income. And there's just an amazing linkage between things like, all right, you have a crowded house. You don't have enough space for everybody. Well, that is a drain on your mental health. You also are more likely to get asthma, more likely to be obese. You can see that every one of these social determinants of health are linked to higher obesity prevalence. And given the fact that, you know, about half of our community members are overweight or obese, that's a really serious thing. And so the thing that excites me about social determinants of health is the idea that big health systems like Kaiser are deciding, I want to put money in those upstream factors. I want to do my grants and fund programs that tackle how can we pull people out of poverty? How can we make sure they get a bachelor's degree? How can we make sure that they have affordable housing? Because they know, this data shows, you are actually impacting your healthcare outcomes and your patient expenditures, everything, by simply addressing those upstream factors. This is another website that I love that goes into social determinants of health. So this is called the California Healthy Places Index. And this pulls together about 20, I want to say 22 or 27 indicators to talk about overall health. And Riverside County, as you can see, we're doing pretty well compared to other California census tracts. We're doing better than 71.9. But What I like is the ability to disaggregate. Let's take a look at it real quick. So some of the indicators that it includes are things like poverty, median household income, of course, whether or not you have a bachelor's degree, but also things like, are people able to actively commute on bicycles? Do they have a high voter turnout? Is alcohol easy for them to get? Are there supermarkets, or does it take forever to get to the store? Are they able to breathe clean air and drink clean water? So all of these factors go into their overall index, but you can also look at just one of these. So for instance, let's zoom in on us here. Come here. So for instance, low income homeowners, severe, let's do renters instead. I find that more interesting. So this is people who are renting, who are spending more than 30% of their income on housing. And that means they don't have any safety net. If something big happens, they are screwed, for lack of a better word. You can see here which neighborhoods have higher proportions, which have lower. Let's go look at Riverside, down to the census tract. So it's super, super interesting, and I highly recommend you poke around on it. Really, really fun. And allows you to dig into why some of these communities are more disadvantaged. Why does 10 miles make a huge difference in their quality of life, in their social determinants of health? And this allows you to dig down and see some of that. So I want to talk about a potential scenario that really underlines why social determinants of health matter. So let's say everything has happened wonderfully. You've gone to medical school. You've done your residency. You're a primary care provider, and you practice here in the Inland Empire because we need you here. Don't go away. And let's say, I was going to ask a poll about this. That reminds me. Let's see. So how familiar are each of you with diabetes? My options I put are super familiar. You're a diabetic yourself. Very familiar, since you're biology majors. Maybe I'm sorry, the cat really wants to be a part of this conversation. Let me text my husband to strangle the cat. Hold on. So it looks like you all are feeling pretty familiar about diabetes. Okay, awesome. So most of you are very familiar, some of you are somewhat familiar. So that's good, because my scenario kind of counted on you knowing some of the basics. So I'm glad nobody said not very familiar. So let's do this scenario. You're a practicing primary care provider, and your patient, we'll call her Maria. She has diabetes, she's Hispanic, and she's in her mid-30s. So pretty typical for our community here. And she continually has really poor health outcomes. Her A1C is really elevated, indicating that she's not in good control of her diabetes. She's overweight. You've been seeing her for 2 years, and she doesn't seem to be making any progress. You provided her with great care over these 2 years. You've explained the behavior changes she needs to make. You've explained that she needs to eat healthy. She needs to lose some weight. She needs to limit her carbs and start exercising. You've explained that this is a really serious thing, that if she ignores this, there's major consequences. She could go blind, she could lose her feet, she could die. It's one of the top 10 leading causes of death in our county, diabetes. So what social determinants might be impacting her inability to manage her diabetes? So the first one, cultural background. She's Mexican, and so tortillas are a staple of almost all of her meals. I was talking once to the CEO of our food bank here, and she said, if you're going to tell our Hispanic Latino community that you need to cut out tortillas, tortillas aren't just a part of the meal. They're also your utensil, they're your napkin. They serve so many purposes. And let's say that Maria has a really close connection to her mother and her grandmother. They enjoy cooking together and they make their traditional meals the same way that they've done it for 100 years. And that's something she values. I know I value cooking with my family. And if she were to eliminate tortillas from her diet, she feels like she would lose that connection. That would take away all of her favorite meals. Now let's talk about unemployment, or employment, not unemployment. Maria is employed. In fact, she has a pretty good job. She's a 911 operator. She makes more than a lot of her friends, but it's sitting at a desk with a computer all day, and it's super high stress, right? She's listening to these terrible situations as they're happening. And when the calls are coming in fast, she doesn't have time to be like, oh, it's my lunch break now. I'm going to take off. Sorry, your house is burning down. That's not an option for her. So she's got a pretty stressful job. And so when you have been telling her, eat little meals throughout the day so that your blood sugar doesn't fluctuate so much, that's just not possible. There's times when she goes hours without it. And she, when you've been saying, oh, stand up, walk around, get a standing desk, those are not things that she can do. Okay, so let's talk about other issues. What about her family? She is a mother of 3 kids, 3 kids all below high school, and she is a great mom. But what that means, unfortunately, is she puts them first. And you see this in a lot of Hispanic families. Well, a lot of families, period. But she puts them first. She worries about them. She worries about whether they're getting their exercise or eating healthy, or whether they're sleeping enough, or whether somebody's bullying them in school. But between a full-time job and having 3 kids and a husband, she doesn't have a lot of time to think about herself. And she kind of feels like, if I took time for myself, that would take time away from my family. So that would make me a bad mom. I don't want to be a bad mom. Like, that's a big part of my sense of self, is that I am a great mother. So that's tough for her, right? She doesn't have lots of time to sit there and meditate or anything like that. Now, what about housing? She lives in a 3-bedroom duplex, which sounds nice. It's big, but she lives with her husband and her 3 kids. She'd really love to have a gym or a room where she could do yoga, but there's no place in it. She's got no yard because it's a duplex, so it's not like she can go run around in the backyard with her kids. They're indoors. Maybe her husband works from home, right? So 1 bedroom is their bedroom, 1 is a home office, then 1 has the other 3 little boys. And there is just no space for her to even have, a treadmill or a set of weights. Everything is taken up. Now, what about her neighborhood? She lives on a busy street. The traffic is fast and the sidewalks are not great. There's no lighting after dark. So when you're trying to encourage her to exercise and say, here's some easy ways, take a stroll after dinner. Well, she doesn't feel safe taking a stroll after dinner. She's worried that, and when you're trying to go into these solutions and say, okay, I get that you don't have a yard and you love your kids, so why don't you and the kids go out for a walk in the evening? Well, she's worried that some of the fast drivers are going to run over her 6-year-old, right? She's not going to go out. Maybe she's worried about getting mugged. That evening stroll is not a realistic solution for her. A park. Parks are awesome. Of course, the closest park is about 3 miles away. And she can't, obviously a 6-year-old is not going to walk 3 miles to a park, especially not in an unsafe neighborhood. So that would mean getting the whole family in the car and going to the park, which she does, but not as much as you'd like her to. I put this in and then later realized genetics are not a social determinant of health, but they are a determinant. And strictly speaking, just genetically speaking, Hispanic Latino adults are significantly more likely to have diabetes, and they're more likely to have poor outcomes. So she was at a disadvantage to begin with. Income. So like I said, Maria has a pretty good job, and her husband works part-time, but then he stays home and helps take care of the kids. So they have a combined income of $60,000. Now, initially that sounds pretty okay, but that's, since they have 5 people in their household, that means they're living below 200% of the federal poverty line. There's not a lot of extras. There's not a lot of money available for things like exercise equipment. Maybe healthy food is really expensive. How can she manage that? So when you look at all of these things, all of a sudden it makes a lot of sense why she can't control her diabetes, right? Her A1C is high, and it doesn't mean she doesn't want to. It doesn't mean she doesn't care about her health. It just means there are a lot of aspects that are getting in the way of her managing her disease. So other things to think about, right? Not relevant to Maria, but for other patients. If they don't have insurance, can they afford their insulin if they don't have insurance? What about comprehension? Are they able to understand you? Here in our Coachella Valley, 20%, so 1 in 5 of our local adults didn't graduate from high school and they don't have a GED. So that's a very low level of literacy. Now, don't get me wrong, there are a lot of people who have no higher education who are extremely smart. So don't ever get confused that education equals intelligence. It doesn't. There's a lot of stupid people with PhDs too, and MDs. Don't be one of them. But it does have a lot to do with literacy, right? If you give your patient a handout and they can't really read that, that's not helpful at all, right? One of the things, is language, right? Are you speaking, how good is their English comprehension if you're the one speaking English to them? Another one is food deserts, right? What if the family has only one car and maybe the dad needs that car for his work. So they are stuck walking to 7-Eleven to get their groceries most of the time. And let me tell you, 7-Eleven has a lot of great hot dogs and some chips and some candy bars, but it doesn't have a lot of fresh fruits and vegetables. It doesn't have a lot of whole grains. Think about what foods are available to your patient. And another thing, of course, is access to refrigeration. If you have a patient that's homeless and they need insulin, there is no way that they have a safe place to refrigerate their insulin. So that is just sort of a non-starter, right? And that is why those interventions need to start earlier. You need to start looking at the housing situation before you can tackle the insulin situation, because the housing situation will help solve that insulin situation. So these issues I didn't mean to bum you out and be like, Maria's totally gonna die from her diabetes. Like she's just screwed. I didn't mean to imply that at all. And same thing with your other patients. But what it means is that you really need to be thinking about what's happening outside your clinic, outside your hospital, outside that exam room, because it has way more impact on that patient than the hour that she spends with you, or than the hospital stay where she gets hospitalized. Even that, it's her whole life that has a bigger impact. So you need to think about interventions that will work within the confines of what she already has and figure out a solution that's really culturally competent. So this is why, for one thing, providers need to be allowed to spend enough time with their patients to get to know them. Because you absolutely, she's not going to share these things that she has a stressful job or that she doesn't feel safe walking in her neighborhood. She's not going to share those things if she doesn't feel comfortable with you. So you need to build that rapport. That's another reason why continuity of care is so important. I switched from having a MD to now I have a nurse practitioner. And I think that's the switch that allows me more time with her. Every single appointment I have, she spends at least 45 minutes with me, and she really knows me. Like, one time I was in there crying because I thought our nonprofit was going to end the fiscal year in the red, and I couldn't find enough money to keep us going. And she's sitting in there with me brainstorming organizations that I can ask for grants. Does that have to do with my physical health? No. But she's there trying to problem solve with me and eliminate my stress. And that's the type of care that I value so much. This also really emphasizes why electronic medical records need to have places for this type of information. Because if it's just height, weight, here's her A1C for the past 2 years, she's female and 35 and Hispanic, okay, that's helpful, but it's not as helpful as if it had also, she has a really high stress job. She can't always step away for small meals. Those types of things, there's no way you can remember it from visit to visit. So don't make it so that she has to tell you again and again and again. It should be in her records so that you can tap that, you can look at it beforehand, you can say, okay, I'm going to check in with her and be like, hey, how's your job going? Have you thought about, maybe becoming a supervisor so that you do have a little bit more time? Those types of things. When you are faced with non-compliant patients, which you will be, you need to think about why that non-compliance is happening. Don't think about blame. Why haven't they lost weight? Why haven't they been exercising? Okay, a lot of us feel very guilty about that. I say that as somebody who is overweight, and every time I go to the doctor's office, I'm like, oh my God, she's gonna yell at me. She doesn't. She's very nice about saying, okay, well, have you thought about putting spinach in your smoothies? Think about the why, not, dear God, this patient's never gonna be compliant. Also, I think case management is underrated. Connecting your patients to non-medical services, whether that's food stamps, whether that's helping them get affordable housing, that kind of stuff can change their lives so much, and massively improve their outcomes. So any doctor's office, to my mind, should also have case management worked in with it, so that once you have that electronic medical record that says, hey, she's really struggling with finding a place to live, then you can refer them to case management, get her a place to live, and then once she's stable, she can focus a little bit more on her and her health. I see a comment about health literacy must be hammered home. Absolutely. It is so amazing to me that some people don't get this. So for instance, I learned that not all schools have to have, not all like high schools and elementary schools have to have health education anymore. And I was like, you have to be kidding me. Like, no wonder the kids are obese if you don't teach them about calories in and calories out. Health literacy is so super, super important. And I 100% agree with your comment. Okay, so that's everything I have. I tried to keep it short and sweet. That's everything I have. I know you had a couple of questions if you want to dive into those or use the chat box.
Absolutely. Thank you so much, Dr. LeComte, Hinely, for this amazing presentation. Really appreciate it. We've learned a lot about the health disparities and, social determinants of health. And I think this has opened the eyes of a lot of students. So if we have some time, I'd like to go over a couple of questions we have prepared in advance.
Love
And
it.
if you have like a couple of minutes at the end, the participants can feel free to, leave their questions in the chat and we'll read them and ask them from there.
Awesome.
So for now, let's see. So the first question we have prepared for us today is, just talk to us about your journey into research and like really how has it been being a part of the HRC and, just your entire research journey.
Yeah, so I fell into research. I was so lucked out. I was actually a business major in my undergrad. Um, I thought psychology sounds interesting, but you have to have a doctorate to do anything in psychology that pays any amount of money, and that's stupid. And I don't want to have to get a doctorate. And then I went and got a doctorate instead. But anyways, so I was a business major, and one of the faculty in the business department, she was an industrial organizational psychologist, which is essentially where business and psychology meet. So she's the one who studies gender discrimination and leadership and toxic leadership and things like that. And I took an intro psych class with her, and somehow I impressed her. I'm real surprised because it was at 8 a.m. and I was often hungover. But somehow she saw something in me and she asked if I wanted to be her research assistant. And that was the end of my freshman year. And I just jumped on it because I was a waitress and being a research assistant sounded a lot easier than being a waitress. And so I started doing research when I was 19 and never looked back. I love, love, love it. It's so interesting to me to, okay, you have a question in mind. Let's go find the answers, And often when you're doing research, the answers just bring up more questions, but that's what's intensely interesting. So I worked for her for 3 years, sophomore, junior, senior year, and she's the one who encouraged me to go to grad school, which I was super into because I graduated in 2008 at the height of the recession, and I was like, oh, there are no jobs out there for anyone, especially a brand new college grad with a business degree that anyone else has. So I was able to get into grad school where they actually paid me to go to grad school because I said I would do research with them. And my program was really tough to get into. It was about 1 in 100 acceptance. And my advisor straight up told me that the reason I got in was because I had research experience. There's not a lot of people who come to grad school with years of research experience. So I started doing research there. I was supposed to get what they called a practicum, which was basically like go out and get an internship and do some more research for someone else. I instead got a part-time job as an evaluator at a science museum, which, by the way, is a super awesome job, and kept doing it because it was so interesting. It was like research, but sort of turned on its head. Research is all about, let's find a question that hasn't been answered yet, right? Something that's not known in the field, and then let's find an answer to it. Evaluation isn't worried about advancing the field of knowledge or anything. It's how are these programs working? Are they doing what they're supposed to be doing? If not, how can we make it better? So it uses a lot of the same skills, but not for the same purposes. So it was really a fun complement. And then I ended up getting the job at HARC. I was graduating and I was worried because if you are, and yes, absolutely. In fact, I'll just make you all panelists if that works. So you can show your mic or not, that's totally fine. But so anyways, I just absolutely loved it. And I got this job at HARC because I was worried, again, about being unemployed. Because in IO psychology, you typically either go applied or academic. And my mother is a professor, and I saw what that looked like, and it looked like a lot of work. I did not want to be a professor. Plus, I'd never taught. I just wanted to do research. But a lot of times, that's where the research is done, is at universities. And so I was like, oh my God, I'm never going to find a job where I can do research but not have to be with a university. Oh God, oh God. And then I found this job at HARC, and I was like, oh my God, it's my dream job. It's my dream job. And fortunately, I got it. I don't know how I got it, because to be honest, I looked at the application packages of the other people and they were far more qualified than I was. But fortunately, I did get it and I did prove myself. And now I'm the CEO, but I still get to do a lot of research. That was a caveat. I was like, I don't want to give that up just to chase money and manage other researchers. I'd be way too jealous. So it's been an interesting course. I'm driven a lot by a paranoia of being unemployed, unfortunately.
Thank you so much. Let's see, Jonathan, would you like to go with the second question we prepared?
Oh, yeah, absolutely. Thank you very much. By the way, your presentation was really insightful, really opened my eyes. So my question is, how do you collaborate with other university institutions like UCR to conduct community health research, especially during the pandemic?
Yeah, so we were really fortunate in that before I came to HARC, right when the School of Medicine was being founded, the CEO then went to say, hey, we'd love to have the Dean of the School of Medicine on our board, but we've realized that's probably not realistic. And Dean Old said, no, sure, I think what you're doing is really important. I want to be on your board. And initially, they had planned that whoever they hired as the director of research would be adjunct faculty at UCR, School of Medicine. And I came on board, and Dean Olds nicely, and honestly, he was really right. He was like, you are not qualified enough. You haven't even finished your doctorate yet, by the way. Yeah, I got hired like 4 months before I actually defended my dissertation. And he was like, most of the people here have so many more publications. You're just not qualified. And I was like, rough, but I get it. But by the time he left his position and I had become CEO, it was actually his idea that I become the CEO. And I was like, wow, that's a big shift from somebody who didn't think I was qualified to be on his faculty. And he said, no, you impressed me, and you have the experience now that you didn't have 3 years ago. So then he went to the Cayman Islands or something. I don't know. He's running a medical school there. But that relationship that we had really stayed, and we were really fortunate that way. So the piece of the School of Medicine that was really relevant to HARC was the Center for Healthy Communities, which is now called something entirely different that I can never remember. I still just call it Center for Healthy Communities. So I was asked to be on their advisory board because they wanted to talk to people who are out working with direct services with the public. HARC is always kind of that weird one. We don't do a lot of direct service, but we evaluate programs for people who do direct service, and we do research, but in the community. And so slowly but surely, I really built relationships with some of the team at UCR School of Medicine. And so now I'm fortunate in that when they want to do something that's community engaged, they turn to me. So for instance, I am a subcontract on an NIH grant, a 5-year grant that's looking at air quality in the Coachella Valley. And just now, this month, we've had 2 other opportunities that came up through the NIH, and looking at racial disparities in COVID-19 testing. And again, they came to me to ask me for help with that, to ask me, how would you reach these people? How could you do the surveying of people to find out what are their attitudes and beliefs? You know, what's preventing people from getting tested or from getting vaccinated? How does that vary based on geography and based on race, ethnicity? And can you do that research? Yes, of course I can. And then they will take that information and use that and create a toolkit to help people do culturally competent work around COVID-19 and help get people immunized and tested and so on and so forth. So honestly, I've just been really, really thrilled with that collaboration. And it really is just a networking thing, right? Other researchers at other universities don't call me because they don't know me. It's really one of those things that it is about who you know, and it's about nurturing those relationships. And I'm so fortunate to have that relationship that I do have with School of Medicine, because they're awesome and they do community engaged research. And I really respect, I respect the values of the medical school, and I love being involved with them. But I'm also really fortunate that I'm always a sub-awardee, because NIH grant proposals are out of this world. Like, it's like 400 pages and all these forms, and I don't have the time and bandwidth to put that together. Not only that, I'm not competitive. NIH is very chicken before the egg thing. They like to fund people that they've already been funded. They like to fund successful PIs. I'm not. They would look at mine and be like, also, you don't have the capacity to do this. You have 5 people. So this allows me to get a small piece of a grant that I would never, ever be eligible for on my own, but I'm happy with that small piece. So I think it's a real win-win. And then they get to look good to the NIH because they're like, look, we have community partners. And also whenever, like for the COVID one, Ann Cheney was like, Jenna, can you get the right people involved? And I was like, sure, because I'm on the board of Borrego Health, which is now the largest federally qualified health center in the United States. And so I was like, I can get you a letter of support in 24 hours. Sure, because I'm a board member and they will listen to me. And I can get you one from Desert Aids Project. So it's good for me. It's good for them. Their proposal looks really strong. I get a small piece of money that I would never be able to get otherwise, and it's been really, really fun, and I'm really hoping we can do more.
Well, thank you very much for answering my question, by the way. And I'll tell Dr. Cheney because she's my PI and Ami's PI, by the way.
Yeah.
Love it. I love Anne. She's so awesome.
Yeah, she's a really great person. Absolutely. Dr. LeComte, Hinely, we have another question. So I understand that the Coachella Valley, a lot like rest of the Inland Empire, has a huge primarily Spanish-speaking Latinx community. So how do you really, reach out to these community members and try to get data from these members?
It's true. Generally speaking, if you're just talking general population, it's not that hard. It's like reaching anyone else. But we have a huge population that are migrant farm workers, and they are not looped into a lot of the systems of care, right? So if you were expecting to catch them in a hospital, that's not going to happen. Also, a lot of them are undocumented and are really scared to talk to anybody about this. So that's where the partners come in. A surprising amount of the work I do is, well, before COVID, now it's different, but before COVID, I went to a lot of meetings. I participated in a lot of collaboratives. I went to a lot of lectures that didn't seem to have any real relevance to what I was doing at that moment in time. But because of that, we are friends with more than 100 local organizations who do the direct service. So for instance, I can say, hey, you know what? I'm going to partner with a free clinic. They treat the vast majority of people who are uninsured here because there's only one free clinic and there's no place else. And they're a good friend of mine. And they can benefit from the data that I share with them. That's where the sharing the data for free really gives you currency, right? They want to know these answers too. So I say, hey, will you help me reach this population? Can I talk to your patients? Can I ask if you'll help me recruit a focus group? Can I put surveys in your lobby? And by and large, they almost always say yes, right? And so whether it's the food banks, everybody goes to the food banks. Another really key partner has been the faith community, right? So you go to the Catholic Church and you say, hey, will you make an announcement to your members? Sorry, I'm not religious. I don't know all the terminology. Parishioners, I'm not sure. But say, hey, this is important. We need to know about their health. And that's something that if they hear it from their priest, that makes a huge difference, right? If you just hear on the radio, like say, for instance, we did some research about getting tested for HIV. And if you hear on the radio, every adult and teenager should be tested for HIV at least once. Go get tested, know your status. You're like, yeah, that's nice. But if your priest says it and you're highly religious, oh, okay, somebody I trust said that, I will go do that. So you have to go to where people are. And that's where the partnerships are so invaluable. And that's why I spend so much time. These same partners will call me up and be like, hey, I'm doing this grant proposal. I don't know where to find data for this. Can you help me? And I'm like, yeah, give me an hour. I'll send you everything you need. And they're so grateful, but it's a mutually beneficial relationship, right? I help them. And then when it comes time for me to say, wow, I really need to talk to this community that doesn't talk to outsiders, I have an in where they can say, you know what, I'll go do that for you. So again, relationship building is so super important to do in community-based research.
Absolutely. Thank you so much. That was really insightful. Raul, would you like to go next?
Yeah. Hi, Dr. LeComte. Hinely. I'm Rahul. I'm the vice president of the Biomedical Ethics Club. And the question I have for you is, you kind of touched on it in the previous question, but how has COVID affected your research and your ability to do research?
So much. It's so annoying. So for example, like I said, we're doing this project for Desert Healthcare District. And we had planned before the pandemic some awesome community engagement. We have a partner that does door-to-door canvassing. Most of their work is get out the vote, and that sort of thing, but they go based on sort of the promotoris model, right? So they are from that neighborhood, they go around and they're well trained, and then they go around and knock on doors and they talk to their friends and neighbors and educate them, and they can collect data that way. And they've done that for us in the past. It was super awesome. They knock on doors in some of the farm worker communities for us. They talked to 400 people in the unincorporated area of Mecca in one single weekend with 20 people. Like, it was crazy how good they are. So I had planned to hire them again, but now door to door does not sound smart. I know I'm not opening my door and talking to somebody face to face. So, and then we were going to do focus groups at various places, at community centers, at senior centers. None of those places are open either. So the first thing we did was stall in the hopes that this would have been a quick thing and it would have been over and we could go back to business as usual. Obviously, that hasn't worked for anyone, despite the fact that all of America tried that tactic too. So now we're doing virtual focus groups, but we're still going to those same partners. So despite the fact that work isn't being done at the senior center has done some great programming online. And yes, I'm sure there are some of their participants who are not engaging, but they are getting hundreds of people to tune into their Facebook Live every single day. So obviously, they've still got those connections. So I'm still going to ask them, hey, would you help me recruit 6 to 10 people who might be willing to do a Zoom focus group with me? We are starting that on Monday. Then we're going to make sure that, obviously, again, we're still talking to partners like the free clinic, like the churches, partners like that that can reach the hard to reach population. But I'm concerned, especially in terms of internet access and internet capabilities, right? Like how we had trouble getting on Zoom, and we're all educated people who do this all the time, right? So I am concerned that we will leave some people out. And so what I have proposed is that at the end of the focus groups, we take a look at who's in the population and who's missing. And then if we are missing, so for instance, if we're missing seniors, if we're missing the farm workers who live in the far East Valley and don't have internet, then we'll go to the few places that are still open and do, sit in the lobby of the free clinic with a sign that says, hey, come talk to me. I'll give you a $25 gift certificate if you come talk to me for a half an hour. And we've always had good luck with that in the past. So I'm hoping COVID hasn't changed that. Obviously, I wrote in that we'd be sanitizing any handouts in between. Everybody wears masks. So it's still a challenge, but the internet thing is the biggest concern for me. We have a lot of people in the East Valley who don't have internet connectivity. On the plus side, the pandemic has actually improved internet access a little bit. Since all of our schools have to do online learning and some of these kids don't have access, the schools went out and got money and provided hotspots and some Chromebooks for some of these households that otherwise the kids couldn't go to school. So their access is actually improved, which is an unexpected bonus, but it's still not great. So I'm still concerned about not getting the voices of some of the people who have the highest need, but we're working through it.
Thank you. Yeah, it's been a struggle with my own research as well. Even though it's not like community based, it's impacted, and I guess every form of research and everything's been impacted. But
it's so true. Part of this project called for us to share data with various partner organizations. They all came to the table in January. They all were like, sure, we'll share data with you. Public health was like, I'll give it to you right away. The hospitals were like, sure, you can have our data. And then the pandemic hit, and we were like number 8,000 on their priority list.
Yeah.
And I'm trying to be sensitive about that and be like, hi, could you still give me your data? I know you're like literally battling a pandemic and literally saving people's lives, but can you send me your data? And it has not worked out as planned. And our client was a little upset about it. And I was like, look, I can't make people share things with me, and I can't make this a priority for them. I wish I could. I mean, if I could make people do things like that, my nonprofit wouldn't be so financially precarious all the time. And life would be pretty great, but you can't, it has changed so much, and it's hard. I wish I had a golden bullet, a perfect answer for you, but I do not.
Well, I appreciate the answer you gave. Thank you.
Hi, I have a question. I'm the secretary of Biomedical Ethics, and I really enjoyed your presentation, Doctor. It's very refreshing to learn and relearn how important the social determinants of health really are. So my question for you is, what skills does HARC look for in potential researchers who wish to become a part of the team now or down the line or just eventually? Because the stuff you do is really important.
Thank you. Yeah, that's a really good question. And I have been really fortunate, and obviously there's 5 of us. I don't have a lot of turnover, I like to think, because we're an awesome place to work. But we do, we do hire from time to time. I just lost one of my researchers because he went off to graduate school, which is the second one I've lost to graduate school, but I feel like that's a really good way to go. You give them all this research experience and they want to go get another degree. So it works. One is getting her PhD and the other is he's getting his master's in public health. So I think, obviously I look for somebody who has some experience with statistics, right? I want them to be able to run some analyses. That's something that's not super easy to teach. I think that's what I focus on, right? What is what are the things that I can teach them in a day or two versus the things that are really, really hard? So for instance, because we do research in the Coachella Valley and I don't speak Spanish, I want somebody who's fully fluent in Spanish, reading, writing, and speaking. Because that's not something you can pick up in a heartbeat. That's something that's really hard. Versus something like, oh, have you ever done interviews, to collect data? Have you ever hosted a focus group to collect data? You haven't? Well, that I can teach you in a couple of days. But if you have that experience, bonus points, super awesome. The other piece is really that like community engagement and community organizing. So Jerry, who's the student, the worker who just left, he was at Hark for about 3 years and he just left to go to grad school. I was really happy because he had done an internship with Desert AIDS Project, trying to promote public health stuff. So, okay, you get it, you're on board. He'd also done internships with a couple of senators, including our Congressman Raul Ruiz, who is a physician and really passionate about health, and he's from the Coachella Valley, and he's an immigrant, and he's really passionate about racial equity. And so I was like, okay, like you worked for people that get it, that get health equity, that get health promotion, that get the idea of community-based health. You have some experience in policy stuff, which I don't have, so I think that's really cool. And then his replacement that I hired, Amarani, she had done some research in her undergraduate degree. She was a part of a research team. So she'd only done it for like 1 semester, but still better than nothing, right? And she had done research on the topic of generational differences between the millennials and then the I generation, and looked at voting issues and how does that differ. And so when I was asking her questions about it, I was able to say, like, what was the most interesting thing that you found? What did you want to explore more? And she showed that interest and that curiosity in diving deeper into those things. And so I think that was a real high point for me as well. So I think obviously intelligence, I do want you to have a degree, although I hired Jerry when he had 1 semester left to go, but I was confident he would be able to finish. Higher education is awesome, but really it's that have you been out in the community? Do you care about your community? Have you been striving to make it better? 2 of my former employees, I hired them because they actually came to me first and were like, hey, I want to do research. Can I volunteer with you? And I was like, sure. Free help. Yes. And they turned out really good. And so after they interned and they volunteered and they did stuff for free, like Chris, my research associate, he started as an unpaid intern with us and he rocked. He was awesome. And so then I said, I'll pay you as just like a contractor. Okay. And then I got the opportunity and we had more projects. I said, I'll put you on a payroll half-time. And then the opportunity came for full-time and I was like, he is awesome. Like if anybody is willing to work for me for free just to get the experience, that is a huge point in their favor. And so actually 3 of my employees, now that I think about it, came to me saying, I want to do community-based research and you're basically the only game in town. Can I volunteer with you? And they did awesome jobs. And that to me was a huge, huge plus. Like I was like, oh yeah, I want her, I want him. Like if you're that interested that you're willing to work for free, you're clearly going to be a researcher. And that's a good sign.
Awesome. Thank you. Very good to know.
As versus one time we had this one intern and I was all excited about it because, again, one of our friends was like, hey, you can have this intern. He's paid, but I'll pay his salary. And I was like, heck yes, I want that. We asked him at the end of his internship what his favorite part of the internship was, and he said, shredding paper. And I was like, you are not going to be a researcher. Like, no. He hated being inside all day. Like, it was not up his alley. And I was like, oh, next. Yeah, so you can tell fairly early on usually.
Oh, absolutely. So the last question we have prepared for you today is, what advice would you have for any undergraduates who aspire to pursue a career in community health research, especially here in the Inland Empire and rest of Southern California?
So first off, yes, it's wonderful. You should do that. You should stay here. You should practice here. We need you. We need more doctors. We need more community health researchers. I would say you guys are already on an awesome track. Like I said, I would not have done this on a Friday night when I was in college. So you're already way ahead of me. So pursuing any learning opportunities is really important. Like I said, volunteering, if you want to volunteer with some community health researchers, there's some awesome teams doing great stuff right there at UCR with you. And I'm so excited to hear that some of you are already working with Anne and with others. That's a fantastic thing. And honestly, it's going to put you above others because like I said, that's straight up why I got into grad school, because I had done research as an undergrad. So even if you can't get a paying job doing research as an undergrad, get a job volunteering. And honestly, that looks even better. Like I said, this person cared so much that they did it for free. Heck yes. Like that to me says passion and commitment. So I think that's a huge point. The other thing I think, and since all of you want to be MDs, don't take this the wrong way, but sometimes medical doctors are a little too focused on those clinical health measures and what happens in their hospital, right? And it's not surprising. That's how curriculum often works. And that's one of the reasons why I love the curriculum that's developed at UCR School of Medicine, because there is that focus on the person and the public health aspect. I'm always excited when I see somebody who has an MD and like an MPH, because that means they're thinking about not just the health of the person inside their body, but you're thinking about the person inside their community. That's what public health is, right? So anything you can do to supplement your traditional doctor, MD curriculum with that public health experience and that public health component is awesome, because it's a totally different perspective, but it's so necessary to understanding your patients and understanding those social determinants of health factors that will come in and that will influence them, that I think that's just fantastic. And there's a lot of really cool collaboratives going on at this time. For instance, I'm a part of IE Rise, which is Inland Empire Roadmap for Inclusive Economic, I don't know. Honestly, I cannot recall. But doing great work in the track of health, talking about how can we build a better economy going forward within the track of health? How can we improve people's health outcomes? And again, it's time. It's sometimes it's just listening. But the fact that you guys already have this organization is so awesome, and you're doing great stuff already. I don't have anything above and beyond what you're already doing.
Absolutely. Thank you so much, Dr. LeComte, Hinely. We really appreciate that. So if you have a couple of minutes, I'd like to open up this platform for any of the general members who have joined our meeting. If they have any other questions they would like to ask you personally, or anything about, some individual questions they might have, please feel free to provide them in the chat, or you can also unmute yourself and also put on your webcam if you want to. But if not, just leave your questions in the chat and we'll read them to the doctor.
Yeah, and I totally get it if you don't want to turn on your webcam. The hair, so if you're not prepared to be on the webcam, it's not a good thing. You can't do it unexpectedly.
Right, no, absolutely. We've been like either not getting haircuts or just been giving ourselves haircuts for the last couple of months.
I shaved my husband's head and I felt like I was total white trash. I was like in the bathroom, like shaving his head. But then again, I'm just jealous because I have curly hair and I don't trust myself to cut it. So it's just out and out mess.
So Eduardo or Ravon, if you have any questions, please, feel free to let us know. So while we're waiting on them, if they have any questions, Dr. LeComte Hinely, do you have any recommendations for any type of community health internships that you've come across that you think would be a great opportunity for undergrads to apply for, maybe in the summer or some period of time?
Yes. I don't know if any of you are familiar with Health Career Connections, HCC. It's an awesome program. It's basically based on the principle that we have these fantastic students who are from the Inland Empire, and maybe they go away to college on the East Coast, maybe they go to Riverside, and they're studying health, they're studying to be healthcare providers, and then they end up getting off track because it's summertime, you got to make ends meet, and you end up working in the fields or in fast food, and you get sort of derailed. And so Health Career Connections is based on the idea of, let's give you a full-time paid internship in something in the health field. And so it's 40 hours a week for 10 weeks, and it's pretty affordable for the host organization. I've had 4 HCC interns, and they've all been phenomenal. It's been awesome. And so basically, like, as an organization, I pay like, I want to say like $8,500, and like $7,000 of that goes to paying the student. So I love that, because some internship programs, it'll be like $15,000 and $7,000 of it goes towards administering the program. And don't get me wrong, I get the concept of overhead, and I get that it costs money to run these programs, but should not cost that much money. So what I love about HCC is that they screen the incoming students really well. So as a host site, I have to do 3 interviews. And they tell me who the 3 are. And then I rate who's my first pick, who's my second pick, who's my third pick. And the students do the same thing. They do 3 interviews with different organizations, and they rate who their first pick is and their second pick. And so they're matched based on that. So it's really nice because you don't feel bad for only being able to hire one. You're like, all of these students are going to a really awesome organization. Here in the Coachella Valley or Riverside area, in the Coachella Valley, a lot of them work for the hospitals or some of the other nonprofits. We've had them run programs for us. I'm a big fan of just give somebody a project and then let them run with it. And so I think that's worked out well for my interns. But it's an amazing program, and they have really good support systems. So they'll all have like a group lecture or a group research project. I think it's an amazing, amazing internship program. And if you haven't already heard of it or participated in it, you should go check it out.
Absolutely. Thank you so much for giving us that recommendation. We'll be sure to actually present it on our Instagram handle and talk more about it so other people can apply.
Nice.
I just wanted to say thank you so much for the information that was provided. I found it really helpful, and thank you just so much.
Oh, thank you. I love hearing that. So I'm glad, because sometimes I'm like, is this all stuff everybody knew already? You know, so that's really nice to hear.
Yeah, I really found them really helpful. Thank you so much.
Awesome. Okay, guys. Well, I think it's happy hour. So I hope you all have a fabulous weekend. And of course, my email is here. You can reach out to me at any time if you have a random other question or if you want to talk more. Like I said, HARC is here to be a resource for our community, and we are happy to be here for you.
Absolutely. Thank you so much, Dr. LeComte Hinely. We really appreciate, you taking the time out of your day and spending some time with us and teaching us so much important lessons about, what are the social terms of healthcare and how we can actually be a part of a much larger movement.
Awesome. Well, I'm excited to have you guys as providers who will take care of me when I'm old and decrepit. So, and so many others. So, all right. Thank you all.
Thank you. Have a good weekend.
Thank you,
doctor.
Thank you.